My name is Martin Hutchings. I'm affiliated to the Copenhagen University Hospital in Copenhagen, Denmark, and here at EHA in Stockholm 2018 I've had the privilege to present a critical subgroup analysis of the ECHELON-1 study, which was a randomized controlled study of advanced stage Hodgkin lymphoma, first-line therapy. And that's a situation where one of the standards of care is the so-called ABVD regimen. It's been used since the 1970s and not changed at all in these 40 years. And that's a relatively effective treatment, curing roughly 70% of the patients. There are more effective but also more toxic regimens that are used occasionally and in certain regions. But ABVD leaves a room for improvement and unmet medical need, and that was addressed in the ECHELON-1 study, where a new agent, brentuximab vedotin, which is registered and approved for relapsed refractory disease, was inserted into the chemo regimen and replacing bleomycin, which is a drug that is in the ABVD, and it's a drug that we wanted to get rid of for a long time because it has some undesirable effects, particularly lung toxicity, which is prominent in elderly patients particularly. So essentially a head-to-head comparison between brentuximab vedotin, also called Adcetris, with bleomycin. The primary analysis of this study was published a while ago. It was presented at ASH last year, and it's been published in New England Journal of Medicine. It shows not particularly large, but statistically significant benefit as concerns the primary endpoint, which is something called modified progression-free survival. So that's progression-free survival, as we know, time to progression or death from any cause, but also time to an unsatisfactory treatment response at the end of treatment, followed by any subsequent anti-cancer therapy, being it radiotherapy or systemic treatment. So that's MPFS. Primary endpoint designed to directly compare these two chemotherapy efficacies. And it was statistically significant that there was a small benefit. It's been approved in the US by the FDA on those grounds. In this analysis, we looked at certain subgroup analyses in order to search out subgroups where perhaps the benefit was larger than in others. And these subgroups were indeed pre-specified, so this was in the protocol that these subgroup analyses would be done afterwards. So we're not retrospectively fishing for higher benefit. And the two most important subgroup analyses that we presented here are analyses of stage 3 versus stage 4 patients separately, and analyses of patients with or without the presence of extranodal disease. And essentially what we showed was that in the high-risk subgroups of stage 4 patients or extranodal disease patients, there was indeed a larger benefit of adding brentuximab vedotin to your first-line therapy. And there was even a statistically significant benefit when looking at overall survival, which is always a really important clinical secondary endpoint. And in line with these findings, when you looked at stage 3 or patients without extranodal disease, there was no statistically significant benefit, neither in terms of progression-free survival or modified progression-free survival, or of course overall survival. So it's really interesting and potentially quite clinically useful, particularly in the European setting.